So the other thing is I'm complaining is the title. It's what we know and do not know on pharmacological and non-pharmacological prophylaxis and treatment in pediatric oncology. So I have 200 slides, 199 we don't know anything about, and yeah, little about what we do know. How shall we do it? Shall we discuss it just on when the slides? Maybe, because it's, I mean, as you can see here, it's such a huge topic. Conflicts of interest. So the background, that's what you know. It's infections are a common complication in pediatric oncology. We have more than 50% of the patients have at least one episode of febrile neutropenia, and this is both true for hematological malignancies and sarcoma. This with the sarcoma, it was also new for me that they, I mean, it's more and more intensive, these chemotherapies, especially like for the Ewing's and the rhabdomyosarcoma. And approximately 20% of all hospitalizations is because of an infectious episode, and this bothers especially us. In Germany, we have really problems with the nurses that we have to cut down beds, so we basically spread all our patients with these infectious complications to other wards. So we can discuss this. I show you later in one paper whether we could, you know, diminish this. But for the patients, it has a negative impact on quality of life. I think there we don't have to discuss. Approximately 1/4 of the patients have a bacteremia, and this means that they have to be treated longer. Usually, that's what we say, it's 10 to 14 days. I think we discussed this yesterday, and therefore I'm mentioning this, whether these 10 to 14 days is not evidence-based either. I think this could be like a study we could at one time think about whether we could really reduce this, this time of antibiotics. Approximately 5% go to the ICU, and the mortality overall is quite low, 2%, but still if one kid dies of an infectious complication, that's the major disaster you can ever have on the ward in a way. So I will talk about prophylaxis, and Isha forced me about talking about non-pharmacological prophylaxis, for example, these food restrictions, and pharmacological prophylaxis, and then we move on to therapy, empirical therapy, and therapy of established infections. And this is a little bit, it's another survey we also did, and this is what you were asking for, what the parents actually, what they felt and what they did. And does it have a pointer? No. But here maybe, yeah. What you can see here, this is this yellow bar. More than 20% really suffer from this non-pharmacological prophylaxis. What we think, it's, you know, it's not, it doesn't harm the patient because it does not have any adverse effects from like the medication we give. So let's do this. And I had one colleague always said, you know, you never know, maybe it's good, so we do it. But I think we should really turn it around and say, only if you know that might help, we should do this. So more than 20%, it's a burden for the parents here. And this is like this is what I learned by Bob recently, because he reviewed one of our papers, adherence, we have to say, not compliance anymore. And so the adherence for the different, this is like the restrictions of social context, and the red part of this bar is showing those who did not really adhere, like less than 50%, I think we defined it. And this goes through all these food restrictions. There it's a little bit less, but many patients did not adhere to those recommendations we gave. And this was done, I think, between 1 year after they had finished intensive therapy. So it was not really on the last day, but it was a little bit apart from that. And then moving on to this is like this example, I think, this neutropenic diet, this example for this non-pharmacological prophylaxis. So the theoretical rationale is that we limit here the introduction of potentially harmful pathogens, whether you have an aspergillus and eat it, then it's being thought that, you know, this Aspergillus goes with, when they have especially mucositis, through the gut into the blood, and then it causes the infection. And if you limit these, the burden of the pathogens, we have less infectious complications. So we restrict all, I mean, Andisha said it before, all these food items, so which cannot be peeled or cooked. So I learned, and this is when I started, cook it, peel it, or leave it. So no salad, no fresh vegetables. Maybe it's the kids will like it. No spinach and so on, but no fresh fruit such as strawberries. And this is now exactly this time when they really suffered eating strawberries and no fast food. And then we were starting to think, and I show you different data on that. One is we now had this meta-analysis of randomized studies of the neutropenic diet. And this was mainly done by Paula Robinson in Toronto, and found like 8 studies, 8 randomized studies. 6 were done here in cancer patients, and 1 each in hematopoietic transplant setting, and 1 they combined this. 4 of the studies for adults, 2 in pediatrics, only in pediatrics, and 2 studies combined this. And here, this is interesting, 2 studies were done in India, and 1 in the Netherlands and Italy, and 4 in the United States. And the summary of the results you can see here. These are the forest plots. And if you see here, if they move it here, this bar over here on that side, then means it favors the neutropenic diet. So you don't see here any differences for those who looked in this febrile neutropenia, that the neutropenic diet had a significant impact on the incidence of febrile neutropenia. The bloodstream infection is basically the same. There's only 1 study in adults which found a slight but a significant that the neutropenic diet significantly protects from the bloodstream infection, but these were mostly those were identified as skin contaminants. Therefore, this is that's the only significant results. Major infection, which, you know, is like a huge pot of different, like pneumonia, bloodstream infection, and there were no differences, and 1 even almost favored the non-neutropenic diet, and the mortality here was also the same. And just to make it a little bit shorter, we had now this, and you can see here, it's on the left-hand side, it's an international panel of those. These are pediatric hem-onc persons and pediatric ID persons. We had also a patient representative and so on. And we tried to do this clinical practice guideline. I have to say, we discussed so many times, I mean, 4 panel calls we had, and it was so complicated, more than, and this is probably exactly because we did not have the evidence that it's not harmful, but we tried to get it out of the data we had. But at the end, we really, we agreed on a couple of things, and this is basically ready for submission. I'm waiting like every day that we send it out to the panel again and then send it out. So those clinical practice guidelines now, they include a good practice statement, which is that's what we basically teach our kids what they should do. They follow the normal, the practices for safe food handling, storing, preparation, and consumption outlined by the applicable health authorities. That's not us as the parents, but I mean, you tell them wash your hands before you take the food, and so that's should be kept in mind. And regarding these food restrictions, we split it for cancer kids and for the stem cell transplant setting, but it's the same with different, we weighted it differently. So we suggest that food restrictions not be routinely used for the prevention of infections in pediatric patients with cancer. That's a moderate quality of evidence, and with a low quality of evidence, it's the same for the transplant setting. I did not show, and this is basically what we start then discussing about selected food items. There is no way that we can really prove or disprove that it's harmful or not harmful. If we say like where I live now, like every village has its different, a special sausage. So I don't know whether it's harmful or not, and we cannot say it for the different teas. You find aspergillus on teas and so on, and so this is then, and I think we can argue forever about this, whether they can have whatever, like the strawberry salad, what we allow it, we usually recommend no this bio salad, where but the other is more sterile, that's what we think. And with the nuts we allow it, we don't allow it like the raw meat. We do not allow the raw seafood. Even I think the sushi, I don't know, to be honest, whether we can allow it. On the other hand, I think we should really come to something at least per country, because what I experience is that if they go for rehabilitation afterwards, after their therapy, and then they come back, then they always blame you, oh, you were too strict, or you're not strict enough, because the others do it differently, and everybody does it differently. And even when the parents talk to each other, then you are lost as a doctor, because you always do it wrong in a way. And this, I don't know whether we can harmonize this at all. And if you, the question was, it's a perfect question, if you go to a hospital, and I think also that different doctors and we have these old nurses, they say, oh, well, they explain it to you, it's fine, but I wouldn't use it. We never did it before when in the older days. So everybody does, recommends a little bit differently. It depends a little bit how much you fear of infectious complications. So that's what I wanted to present here for this food restriction, and you said it. It's a very difficult topic, and we have to keep in mind the local way, whether like the tap water you can use or not, and that's very, very difficult really to generalize. So are they? Or I have 3 more with these pets, or 2 more with the pets and the social contacts. Or you want to talk?
So right now, would you say something like a pregnancy diet is something you would recommend? Because then I think in Japan, they say you can have raw seafood, but in Munich, there is no such thing as fresh raw seafood, so we would tell them no. Do you think that's an okay approach? And parents already have heard about it, how it's done?
That's what we do as well, because this is like, they can imagine what that is, and then they can follow this. That's what we think, like the raw milk, anyway, no kids should have raw milk. And then this unposted, yeah, exactly, and this with the cheese, and so yeah, that's what we do as well. But when in Munich, the Irene Schmidt, I talked to her recently, and then they had prepared a little booklet or like a flyer, and then I said, look, what you do is not really, it's not consequent either, because they said, oh, we should be relaxed with this and this, but we are going to forbid this and have these restrictions. But those restrictions are not based on any data either. So we are just talking about this and try to figure out how we will do that. But with a pregnancy diet, I think, yeah.
It sounds good, the pregnancy diet, but then how do you treat honey that we restrict in Israel?
Yeah, this is what I'm saying now.
In yogurt.
Yeah, I mean, we can discuss it. I mean, other give like, I mean, like even the transplant setting in the adults, I'd recently listened to a talk from somebody from the US, and they say like they give probiotics. And so I don't have data against and in favor of this. That's the problem. And we can discuss and go through all the food items and discuss it, and we won't really get to an end. So I don't know. I mean, if somebody has a good idea how to approach this, but you always can come up with something. Oh, the honey is made. I mean, because I don't know about the different kind you prepare honey. Maybe there are different kinds. One has a little bit more pathogens, one has less. I don't know.
Thomas, do you think that the neutropenic diet plays any role, at least for the solid tumors, where the neutropenic phases are very short, usually not in all, but all protocols? Do we need any neutropenic diet in solid tumors?
No, I mean, I don't think we do need any neutropenic diet. I mean, who is going to, I mean, there may be some, but a really minority, but which kid with mucositis is going to eat blue cheese? So it's difficult. I mean, this is really you can discuss without. It's an endless discussion and fruitless.
Any other questions or comments to the neutropenic diet, Rahil?
Just a general diet thing. Have you ever seen an infection where you have attributed the infection to a dietary cause?
No, but there the problem is exactly, I mean, this is a correct question. I mean, the problem is there are some case reports in the literature, and then they point, oh, here, look, this and this happened. I mean, we genotyped the bug, and it was in the blood and in the gut. I don't know whether it was just by chance in the blood and in the gut. I don't know, but these case reports, they always take out. But I think, and this is what you were saying before, we are getting less restrictive over time. But Andisha, there's one.
Ah, sorry.
Is there any data that it actually might be protective because you have a more diverse microbiome if you are allowed to eat?
No, the data are missing, but I would believe in this as well. I mean, this is true. That's what we thought about doing a study like making like this, but then you have to take into account whether how much and what kind of antibiotics they have. But that's true. I mean, that's a good point.
Beyond the infection rates, any difference in other outcomes, say abdominal pain, diarrhea, or other things?
We did not look in this. I mean, this is so difficult because, I mean, if they have, you know, prednisone and if they have whatever, I mean, all right.
Now the pets.
Yeah, but that's only one slide because I don't. We really don't know that much about this, and these pets are often important friends. I don't have to tell you, for children it's a member of the family, but maybe they're the source of pathogen. And when I started, dogs were just, you know, lucky when kids had grandparents where the dog could go to, and otherwise, I don't know how to phrase it nicely. The dog, you know, went away, and so we are now totally different, have a different behavior. And when I was in the US, and it was the mid or end 90s, they had 2 German Shepherds which came to the ward, and this was unthinkable at that time in Germany. And now, I mean, like in Utrecht, they have one, I think, and they asked me recently, they wanted to have it even going to the MRI with a kit, and whether one can do it. But yeah, I don't know how it was decided. So, and this is actually the study you mentioned here, or before what we did. In fact, we looked to we had And it was just pure luck. We had collected in AML the infectious complications for one study for a couple of years. All these infectious complications, we had the flu, this bacteremia, pneumonia, and gastroenteritis. And then we did this survey, how strict those centers were. And then we put those data together and looked whether a stricter center has less infectious complications. And these are the data here. And we did not see this for any food restrictions. We did not see this for the pets. But one has to say, and that's I just show you, and this is not evidence-based either. What we do, and when we were talking before, we leave the pets. They can stay at home. They should be regularly checked by a vet, and they should be vaccinated. And we discourage to buy a new pet during intensive therapy. So, and this is then the normal thing, hand washing after contact, no licking or scratching by pets. That's what we discourage. So they have to be a little bit careful. No pets in the bedroom or in the bed, and they should not clean the bird's cage or the cat litter box. So that's just in general. So we are much more relaxed with the pets, and because people or you made this fun with the turtles. The turtles is they excrete salmonella. So if a turtle goes, I mean, you have a nice turtle without hair going through the kitchen, you have like a trace of salmonella through the kitchen. And this is why we are a little bit careful with these, with the turtle. And this, therefore, we put this question with also with the guinea pig in there. That's all what I can say for the pets. I mean, the problem, for example, is one. I mean, like two things. Is one with this outdoor, the cats getting mice and putting this nicely in front of the door. That's one thing, and the other thing is if they want this horse riding, what we say, and I remember Roland Ammann when I was telling this, and he said, I said, look, oh, this if they go to the barn, that's we don't like this. They should stay out. And he said, I mean, from Switzerland, oh, our kids, some of them live in a barn basically. So, and so everybody has his own. You know, limits what they allow and what they don't allow. And you have also to face what the normal environment is.
I just wanted to comment that so I work in Bristol in southwest England, where there's, you know, we serve a region where there's quite a lot of farmland, and there's some families who live within farming communities, and we have seen children who've then become unwell with invasive fungal infections who live in those environments. I wasn't sure if you knew of any data around that.
Yeah, I mean, then you can think about this. I mean, maybe then you can think about being a little bit more generous with antifungal prophylaxis or so, but it's just a difficult topic.
I think, but this is a very interesting and important question. Who does allow the patients to spend the weekend on a farm if they want to? AML and the survey was about ALL and AML. Who allows patients with acute leukemia to spend a weekend or a week on a farm? Bob, you allow?
Is this one on and all? If they live on a farm, then we let them carry on living there. We don't have a lot of farmland in our patient group in Yorkshire, which is a long way from Bristol. But we've also seen invasive fungal infections, and they haven't all been to Bristol to get them. So I think there might be something else apart from being near Bristol that causes invasive fungal infections. We were just commenting, isn't it amazing that we'll have like a global trial to decide whether or not we're going to give 4 vincristines or 5.5, but you're not allowed to cuddle a guinea pig, vary so enormously, and nobody's ever trialled the addition of guinea pigs to life to see if it's any good. And all those studies on food, none of them went, How do you feel? Can you actually eat that slop that we are telling you is safe? Nobody studied any of those in terms of outcomes, endpoints, and they certainly weren't in the S-demand. But they should be, shouldn't they?
No, I give you, I mean, those studies, most of them are really bad, because then they get antibacterial prophylaxis, they get antifungal prophylaxis in the in the neutropenic diet and non-neutropenic diet trials, and they are in the HEPA-filtered room, and they get antiviral, so they get everything to protect them. And then you say it's no difference, but we should really look in the real-world data on that. But it's hard. I mean, you have so many confounders. That's the problem. Like living in Yorkshire and Bristol.
I think now I'm a little bit teased to also share a story with you. Almost 2 years ago, in Essen, in Germany, the adults saw that they had an elevated fungal infection in the hematology department that was across the IA department that we have. And then they found out, so in the beginning they thought, okay, maybe it's just a month, but then it went on for 2 and 3 months, and then they found out that this infection was due to a construction for the new pediatric clinic in Essen. And then they said we have to shut down all the windows for 2 months till this kind of a construction is done.
Yeah, I mean, that's one reason we don't get.
And they were just in the clinic, the patients.
You don't get a new hospital in Frankfurt. That's true. But no, but this is well known about the construction. Yeah. This is really written all over. And then when we planned, I mean, we were allowed to plan at least to have a new building or so, and then it was like this. And some other, like Würzburg or so, they did. Build the new clinic far away from the older one, because if you tear down those old buildings and put another one next to it, and then you have for a long time these spores.
We have seen this exactly on very low numbers, of course. We see every time when we had construction work, we had very few more fungal infections. So we are very strict nowadays when we perform construction work with antifungal prophylaxis.
Just wanted to add the same thing. Our hospital is celebrating 100 years this year. And the previous director, who became the mayor of Belgrade, decided to rebuild the facade. And in the first week, we had 6 fungal infections. Week 1. Yep.
We also tell our families that they can't do reconstruction in their homes.
Yeah. And I think this could be something we don't recommend, except for the transplant setting, these face masks. But this, if they live close to like a construction, then this, I think, we should recommend.
Do you have any data on having patients in those isolation rooms, hypofiltration rooms? Because if we if we do not have any restrictions on food, beds anymore, or we wouldn't have it, what do we do with that?
I mean, I don't have clear data on that, what that makes. And this is the other problem. If we really want to stratify, what is the HEPA filter room doing good? What is the whatever, this and this and this? Because it's a mix, and that's what I was saying with all these some of these randomized studies, they put all together, they protect it, they put them in a protective environment, and then you cannot really say, is this helpful or not? And Disha, that's the 9th slide out of 46, just telling you.
Then, no burning questions.
No, but please, so, and it's
social contact.
Basically the same. I mean, there's no reason not to meet friends. And when we go for the quality of life, I think this is incredibly, I think, one can discuss, and this is also open, like this daycare and kindergarten, we don't let them in, usually because of the catheter, because if they tear then it's not that good. But just avoid, I mean, if they come home, if they avoid the sick friends, coughing, runny nose, and, you know, like nice varicella exantema, they should stay away. But otherwise, we really encourage them to come home. And the hygiene, such hand washing and so on, is important, and also to vaccinate the close friends if possible, and the family, also us with influenza, chickenpox. Don't ask me about COVID, because this is really, I wouldn't know. It's recommended in Germany that we have to be vaccinated once a year, and the kids as well with cancer. But I mean, this is also probably endless story we can discuss tonight. All right, can we move on?
Recommendations now in your hospital?
You can make a survey, Adisha.
I think Thomas has nicely shown that there's no evidence for most of these restrictions that we have done for years, also in my hospital, and we, at least my hospital, are getting less and less and less restrictive. But it would be interesting of you what you are going now to do in your hospital, or what you would say.
I think one maybe difficult question for me that parents talk together, and so it's very difficult to say, okay, AML, ALL, sarcoma, do that, don't do that for this kind of other treatment, because whenever they talk to one another, they do not always know what the other kid have. And sometimes it gets difficult, and they come and say, yeah, this child can do that, this child can do that. But it's also a burden to be very restrictive, because some parents get nuts, to what I think. I mean, just very, very restrictive, more than what we tell them they should do or not do. And this should also come into the discussion that the reaction of the parents is sometimes, I mean, if they are more stressed about it, then they kind of exaggerate it. And talking to other parents, I mean, if you have weekly vinblastine, then it's not always the same. And but still they talk together, so it's always even more complex than what we think, I guess.
No, I give you right. I mean, it's very complex. And what I think, on the other hand, and we looked at, because somebody was asking this, whether the more restrictions you have, the adherence goes down. This we didn't see. That's what I was expecting, actually. And the other thing is, sometimes it's good to have these restrictions for the parents, because they want to be active and they want to do something, and this can help. But this is just really very indirect benefit. Okay. 36 only. So chemoprophylaxis, and this is another very controversial topic here. The question whether you give it or you don't give it is basically, you want to lower mortality. This you have to ask yourself. You want to lower the incidence of bloodstream infection and febrile neutropenia. On the other hand, what you buy, or the cost of this, let's say, is that you might have a higher resistance rate in the institution, and it might be for the patient, and also the collateral damage. We say it's like the neurological musculoskeletal, like the quinolones have been accused for this. And when we look to the randomized trials, I just put them here together. The antibacterial prophylaxis did not reduce mortality in patients with AML, AL, and in the stem cell setting. However, one has to know that those mortality rates anyway were really low. So it's not that you can expect that they were significantly lowered by the antibiotic prophylaxis. And one study from the COG, it was shown that the prophylaxis with the levofloxacin reduced the bloodstream infection rate in acute leukemia patients, not in the transplant setting. However, one has to say in the control patient group, the rate of bloodstream infection were almost 50%. So that's unusually high. We have like 20–25%. So I'm wondering whether, I mean, how reproducible those, I mean, these are the huge studies. I would not like to do one of those, but this is the only study which showed that the BSI rate was lowered. In the, when we looked at the febrile neutropenia, the prophylaxis rate also was reduced with the quinolones, but not with the amoxicillin clavulanate prophylaxis. There was no effect. And there was no firm conclusion regarding the emergence of resistant and long-term adverse effects. And this is one of the crucial points, because when you do like a clinical practice guidelines with the colleagues from the US, they only go for those data from randomized studies. But what we see, and this is one, I mean, there more than this, but I think this was one study in Germany when they now this is moved, when they introduced the ciprofloxacin in, and there are two different years now, in the 1980s, then you see here that the resistance rate not immediately went up, but here after a couple of years, like after 10 years, then it was really high. And the problem is it's not only the resistance rate against ciprofloxacin, but they have this cross-resistant rate. Like if you look here to the ampicillin or also to aminoglycosides, they have a lot of cross-resistance, and this makes the problems. And when there was a panel with the US colleagues, and they said, oh, it's a weak recommendation for this AML and relapses of leukemia, that it's the antibacterial prophylaxis is recommended. But when we only went to the ACIL 8 guidelines, and ACIL stands like, it's this a joint venture of the EORTC, the EBMT, the Immunocompromised Host Society. And when we looked to this, we said the routine antibacterial prophylaxis is not recommended for our patients. And we valued this emergence of resistance quite high, more than the US colleagues did this, because it's not from the randomized data, but it's clear from the observational data that this emergence of resistance is really getting much higher when you start doing this. And I have one more slide here, because this is another issue in AML. What we know, the viridans group, streptococci, this VGS, might be a problem, but when you look to the mortality due to VGS, then you see here it's 1%. It's here none of the patients died, 2%, less than 1%, and here also less 0%. So what we do, and this is there's also like an ongoing discussion. I mean, you know this, and I mean. I'm totally against this prophylaxis, this teicoplanin prophylaxis every other day. It was published. It's not a randomized, and there I would say it's not a randomized study. And what we see, we don't give prophylaxis, but we early institute. Usually, if they come, we give a glycopeptide in combination with another one, like peptides or so. And we haven't seen any really mortality over the last years if you do this right away. Then we can stop it after 1 or 2 days. If the kid is fine, we don't see any of this. But this is like, I wanted to show this slide because there's a special fear in AML patients, which, yeah, I can understand it was before, but now we haven't really seen very, very bad bacterial infections, at least in our patient population. This was with this antibacterial prophylaxis. Shall we discuss this? Who is giving antibacterial prophylaxis in any patient population? Let's say, especially except for the transplant setting. What do you give? Who's doing the same? Oh, Bob. Right.
A question and an answer to that. So we would give ciprofloxacin and prophylaxis to patients with Down syndrome who are being treated for acute leukemia. I'm not sure where the evidence lies for that, but it certainly has been our institutional practice for quite a long time, and we probably would apply that to other patients with maybe specific patient factors we're particularly worried about, infections, maybe other types of syndromes, or other comorbidities as well. I'm interested if there's any data to support that practice or not.
I don't know. I mean, we did not see, when we looked to the AML patients, we did not see that it was really much higher, the infectious rate. And when we looked to the fungal infections in the last ALL trial, we did not see that the Down syndrome had any, the incidence was higher. What we don't know in the last trial, whether they got prophylaxis or not, maybe people are more, they want to prophylax them. I mean, it's true that the complication rate is higher in those patients, but we don't give them extra prophylaxis.
Henrik. Thank you. Just a few comments. We are using teicoplanin, but in a randomized study. So we will find out with some time for AML patients. And I agree the mortality of Streptococci in AML patients is low, but the morbidity is very high. Many of them end up in intensive care. So if we could reduce the morbidity from VGS, it would be important. And then the second comment is that I just learned that the infant ALL protocol, the new protocol, had two, I think, E. coli death among the first 11 or 12 patients, and they will recommend quinolones for future infant ALL patients. I don't know how evidence-based it is, but that's what is from the protocol.
I mean, we did not see any of our AML patients going to the intensive care because of VGS either. So what I personally think, if they really come early with febrile neutropenia, if you start the glycopeptide immediately, then you are fine. That's my personal, my experience, but it's not randomized. It's not a huge number of patients. So I'm looking forward to the data.
I can just comment. I think the reason why we are using the teicoplanin prophylaxis is exactly what you are saying. It was the morbidity, not the mortality. This is the reason why we decided. Of course, it was an unrandomized trial. And with regard to your infant ALL, these two cases happened in one country. And the DSMC recommended this to us, but this is a very difficult recommendation to give antibacterial prophylaxis to all infant ALL patients now. It's a recommendation, what we have written now in the protocol, but I think which kind of antibiotics should we give them? And the problem is that these two cases appeared very early in the study, and it's a very important study, as you know, with the Blina cyclers. It's a difficult situation in the infant ALL trial. It's a very broad sentence within the protocol. So just two quick questions. What do you call early institution of a glycopeptide? And the second one is, how do you treat AML patients after chemo? Do you treat them as outpatients?
Yeah, the first question I didn't.
What do you call early institution of glycopeptide?
Why or what?
What is that? More than 48 hours of fever, or?
No. They come. If they have febrile neutropenia, they come immediately to our hospital, and then we start glycopeptide immediately as a first-line empirical therapy. And I think with this we are pretty fine because we don't wait that long.
I don't recall ever seeing a patient with VGS infection and having mortality out of it. Even if we keep the patients after AML treatment.
No, we don't do this anymore. And now we just analyze this. I will come to this, whether you can, how long you have to treat them. And we used to treat them also, or we even we treated them quite long, then we stopped treatment after febrile neutropenia, and then they were still neutropenic, and we kept them in the hospital, and now we sent them home. And it works so far. Okay, I have 1 minute for... I think this is easier now. No, I mean, the antifungal prophylaxis, what these ISIL guidelines recommend, it's if you have, and this is a natural risk of invasive fungal disease. We don't know this for many, especially for the new protocols, including new compounds. We don't know this. If this is 10% and higher, this is what we know in the data we have in AML, in relapsed acute leukemia, in allostem cell transplantation, this is definitely higher than 10%. In ALL, you can see here, this is in 2 boxes, less than 5% and higher than 10%. We know by experience that there are some patients we haven't defined for a long time. We know that they really have a high risk for invasive fungal disease, and we usually know, okay, these older ones, and then they're all with this high risk group, but the high risk group, we often knew it after really several weeks. And so it was depending on the protocol, comorbidity and age, so it was less or more than 10%. And we did now this study in the IOPFM ALL 2009, and what we saw that those older than 12 years, they approached this 10% hurdle. But I have to say, we don't know which patient had received prophylaxis. You cannot do this except that we really go one by one and follow this prospectively. Like if you give for some of these compounds, you can use it for empirical treatment or prophylaxis, and they don't have a different schedule and a different dosage. So it's really retrospectively, or you cannot really know except you ask the treating doctor. And the other thing is, or the other risk factor was that they had a blast count more than 10% on day 15, which is quite early. So according to this, now we start prophylaxing our patient, and that this is important. Also, we know that the incidence of proven probable infection is less than 4% overall. We know, and this was for me quite worrying, that in this multivariate analysis, the proven probable IFD significantly impacted on the event-free survival and on the overall survival. So it's important really to prevent these infections in those patients, and that it has this effect on the overall outcome. Probably is because you delay and you decrease the intensity of chemotherapy, and therefore the outcome is worse. And the question, and that's the real question, what do we give as prophylaxis? We have this POSA, ETRA, this azole, these voriconazoles in hand, but we cannot use this for ALL usually because it has this contraindication with the vincristine, with these drug-drug interactions. We can use it, and I think this posaconazole now is also licensed for children from, I think, 2 years and older. And so I think that's a good drug if you, for example, for AML patients which has this, have this kind of block therapy. What we do, and many others do, is this liposomal amphotericin B. This is only IV applicable. We have various dosing regimen with this extended doses. We give twice a week, 2.5 milligrams per kilo, which is not, I mean, proven that it works, and it's also not approved for prophylaxis so far. The health insurance, they haven't seen it, or they are not aware of this, but I mean, we just do it. And the same is micafungin, caspofungin. For the micafungin, there are also different dosing schedules. The caspofungin is actually the only randomized study which showed a decrease of overall invasive fungal disease and also invasive aspergillosis in AML kids. This was basically the same study as with the levofloxacin. But then you can say that those received during neutropenia everyday caspofungin, and this is as prophylaxis, but this is exactly the same as empirical therapy. So, and that's what I wanted to say with this antifungal prophylaxis. I mean, this is a tricky issue because we don't, except for the caspofungin, we don't have any good data to really support any of like this liposomal amphotericin B or this micafungin. I think posaconazole, we have the adult data. This will work, but again, we have these problems with the ALL patients. Comments on that? Yeah.
Do you recommend drug monitoring while giving posaconazole? Because we struggle quite a bit with getting, we drug monitor and it's, we have to up the dosage and up the dosage, especially for the ones receiving the formula.
Yeah, that's the, if you, with the solution, yes. I mean, there are two different kinds of preparations. One is the slow release tablets, what the adults use. You can have this as a tablet. And now it's also available as this, it's called a slow release solution. So this is like the tablet, like a crushed tablet. If you have the old solution, and I don't know how long they will be produced, then you should do the drug monitoring, because especially the younger kids don't reach the level. If you have this, the slow release tablets, which are then licensed for those, which is, I don't understand it, like 2 years and more than 40 kilos. I don't know which kid has more than 40 kilos with 2 years, but then you don't have to do it, because the levels are really reliable and reliable within the level you wanted to have.
Okay, and then just one also with the azoles in the patients receiving vincristine. For instance, I know we can't give it together, but some patients we will give posaconazole as their prophylaxis, and then we will stop it and then give it again.
Yeah, probably it's 2 days before and after, but what we experience is that people forget it, and then we had to move and to postpone vincristine, because then they, oh, I gave this posaconazole this morning, and this is not good either.
I'm sorry. I have a question. I don't know if it's the same thing in other countries as well, but do you not use fluconazole as a first step? Isn't it too much if you step it up to all these other ones? Do you not fear resistance?
There are no data on resistance, whether we increase the resistance rate with those. I mean, there are azole resistance increasing probably. But with the fluconazole, I mean, if you look to the ALL data, for example, we have like 2/3 of mold infection and 1/3 of Candida infection, and also Candida, there are increasing number resistant to fluconazole. So what we think that you can do this, I mean, especially like in Latin America, so they often don't have these compounds, these mold active compounds. If they do this as prophylaxis, it's better than nothing, but then they have to do more like this galactomannan and so on to check whether there's a mold infection, which we don't recommend in mold active prophylaxis. So I think it's less, I mean, I would recommend, and that's what we do, we would recommend is in those patients we usually face giving a mold active prophylaxis, because the likelihood is so much higher to have a mold than a Candida.
Thomas, may I ask you one question? Our AOPFM 2009 trial, where we showed this cutoff of 12 years, and you said in Frankfurt you're really strict now to give no prophylaxis to below 12. But
I
we
tell
know.
you,
okay, it's not so strict.
No. We were strict, and we had one who was really a terrible infection with 11.5.
And I think our.
And now we just we go a little bit more the gut feeling, but that's what we always do, and you're not rational anymore. You're not consequent. You have the data, but then, this was...
Because the incidence is not 0 below 12 years.
No,
it's not 0, and that's why I'm asking you.
No. Okay. Good. Then we go to febrile neutropenia, which is also, I think this is easier. I mean, we know that it's an immediate clinical evaluation by trained medical staff with the signs of sepsis. You have here the red flag there, and this is a different story when you have a sepsis. The golden hour, I mean, the data from Bern, they just question whether we have to have the golden hour, like this coming to the hospital, and then within 1 hour you take the blood cultures and treat the patient, and you start the antibiotic treatment. And what we also know, and I don't want to go into this, it's basic daily evaluation, even more often in case of clinical deterioration. I mean, more, it's this recommendation, and then it's also a matter of discussion. Obtain blood cultures at the onset of fever from all lumens of their central venous catheter. That's a strong recommendation in all these guidelines we've given. So I think this is clear, but there are different opinions on, and therefore we wrote, considering obtaining peripheral blood cultures concurrent with a central venous catheter culture. It's a weak recommendation. We know that about 10% and maybe even higher, the yield of a positive blood culture is if you do a peripheral blood cultures at the same time. Whether this has a clinical impact, we don't know. And I think in Germany, we have our guidelines. We do not really recommend this. But I mean, I know that there are some hospitals which usually do it because of these 10%. You know, that you can increase the yield of a positive blood culture. The same is basically true for the urine analysis. So we say, if you get it easily, just do it. If you don't get it, don't, give fluid, and then you wait, and so on. So this delays everything. But we are also quite clear in the chest this chest X-ray only if you really have respiratory signs or symptoms. The blood biomarkers, it's just a leftover, I have to be honest, from another talk which was in Milan. Thank you. And so this is another thing, this is like, because our intensive care unit, they always say if they come, they have to do an IL-6 and so on, but we don't do this. Questions, comment on that, because this can also be very controversial. Bob is looking already.
May I ask, urine analysis, we never look for the urine, I have not seen.
Oh, we had now twice.
Okay, but we haven't seen. Who is doing urine analysis in all patients coming with febrile? Interesting. Bob.
We're currently doing a systematic review of the studies in febrile neutropenia looking at urine analysis and the association with signs, symptoms or existing urinary pathologies. Also trying to look at age to see is it different in the 2-year-old and under versus the potty trained and older. And it's a very good idea to do peripheral blood cultures. Don't listen to him. Because you will pick up things that you didn't get on the central venous blood culture, and that's because some of the bugs hide in the fingertips and only come out when a needle goes in the child's hand. It's the only explanation I've got for it.
Just a question back to you. I mean, how often did this really influence your antibiotic therapy, or would you have gotten those pathogens without?
Yeah, so the majority of pathogens that grow in the peripheral also grow in the central, but there is around about 1 in 11, 1 in 12, if you look at the meta-analytic data, that only grows in peripheral and doesn't grow in central, and isn't a contaminant.
No, but I mean, I'm asking whether it really affects your...
Yeah. So every in our centre, every 6 months or so, usually just after the doctors are just about to leave, because we rotate them every 6 months, and they spend 5.5 months going, stopping small children. And then just before they're about to leave, we get one that comes through that actually has a change in resistance pattern or something about it that extends the duration of antibiotics that we would give and makes a clinical difference. And then that lot of doctors move on and we get a new lot in that go, and they don't listen to us, and it takes ages to persuade them of that again.
I mean, we explained the...
So, we looked at that in the meta-analysis, and if you double the volume that comes out of the central line, you do not get the same as if you do the peripheral, and it's because they're hiding in the fingertips. They know, the bugs know that if they hide there, they won't get caught, but they're just irresistibly drawn to the act of pain.
But do you stick to the necessary blood volume? I mean, that's another bad thing. Usually they
so
just a little bit.
In various senses, we have done an analysis of the blood volume. There are a couple of studies that looked at blood volume, and pathetic blood volumes leads to a really, really impressively low rate of bacteremia because you don't have enough bugs to grow them in. But when we've done sort of QI cycles, then it's still the case that the peripheral blood volume, if you use the different bottles, you know, the drain the child bottle for the central and the 2 drops bottle for the other, yeah.
Now you can imagine how the recommendations are being made if 10 like Bob and me are together and fighting.
I remember the first time we put all this together, there was nearly a stand-up fight between 2 sides of the table as people with very, very strong opinions.
But no data.
And culturally into arguing were placed on either side of the table. Security arrived, it was all fine.
Just a question. And direct it to Bob, since he said regarding the peripheral cultures. We're working on a febrile neutropenia guideline in Malta, and this is one of the things which is on the cards. Basically, should we take peripheral cultures?
Don't ask him.
Usually we take cultures every 24 hours if they're febrile. No.
So there's good data from the Australians that repeating cultures on a daily or twice daily basis is really good for making your lab people do extra work, and that's its only benefit. Yes, you get lab-induced anemia as well. So repeating the cultures on a daily basis is probably unhelpful unless there's a clinical change in circumstances. In the 400-odd positive cultures that Gab had, only 2 of them were positive on a repeat sample that weren't positive on the initial. You know, so that continuing to surveil almost is a really unhelpful thing to do. And I would absolutely not suggest doing that on that basis of that data.
Thank you.
Oh, there we agree.
Okay. The one agreement we have.
Good. So,
Thomas, do you think we can finish around 6?
No.
Okay.
No, I can go through this quickly. I mean, the slides, we give them later as a PDF, or? Yeah, good. So then the choice of initial empiric antibiotic therapy, consider institutional microbiological resistance patterns. So you have to know what you are having in your hospital, and also specific patient factors, and also the initial presentation. Therefore, you basically have those. I mean, these are the normal patients, clinical stable, low risk of resistant infection. And then you have these with the sepsis signs, and this is getting more and more complicated if you have those patients, and if they come from Bob to our hospital and they have a lot of resistant pathogens, and then you have to think, do you change your initial empiric therapy, yes or no? And that's what we do usually. We have a sticker somewhere in the computer. No, our computer don't work now. we have this cyber, now we had a cyber attack, and so we have a sticker somewhere, and then they're saying, look, if this patient comes with febrile neutropenia, just change this to that. And then the question I just go through quickly, and usually it's recommended a monotherapy, and the meta-analysis did not show, even for the high-risk patient, that that the combination there, like a combination with an aminoglycoside, is of benefit. We do it, we stop it usually with the next day, and within the last year we had 2 which would not have responded to the peptides we usually use. So, but we don't know where the threshold is, whether you have a 2% resistance rate in your hospital or whatever, but that's how we do it. I don't go this with the signs of sepsis, and you broaden it up with the carbapenem, and usually like with or without a second gram-negative agent, and with or without a glycopeptide. I think that's especially when those AML patients come in, and that's what we were talking about already, this clinically stable with previous infection with a resistant pathogen, or colonized with a resistant pathogen. The question is then, when to stop antibiotic therapy, what we do, and these are the recommendations. Just discontinue all empirical antibiotics in patients with a low risk. I come to this, or in some patients at a high risk, if they are afebrile, and then there are a little bit difference in the recommendation whether it's after 48. We think it's 72 hours, because you have to wait till the negative blood culture is really negative, and we do this independent, and these are the recommendations, independent of hematological recovery. And then you go back to what is your risk stratification, but this you should do, and there are some risk stratification, and what we suggest, look at those and make your own risk stratification, what you have in hand. Not everybody has all this full blood count in hand in the night and so on. So this is then the risk stratification. The real data, the real world data look differently, that 42 centers of the centers do not discontinue antibiotics prior to hematological recovery. That's exactly the same what you do with the SOPs, and then nobody really follows those. And this de-escalation and also the dosage of these are the main problems what we face when we look to real world data. That's from Bob, something I skipped this and we don't. No, these are new concepts for early discharge. I think we don't have time for this, but we can discuss this maybe during tonight, that they have a nice, it's called a US rule. It's Australian, UK, and Swiss rule for that they can discharge those patients quite early according how they present. And this works quite well. I think this is good. And but this, for me, the main information also is that you have to, if you're not sure, and especially those patients, just you have to observe them for some time, whether it's 6 hours or 20 hours. I mean, this probably we will have to find out. But you have to keep them. This sometimes we do if you're short of beds. Keep them a little bit, and then you know what the direction will be. That's the main, and look at this paper, it's a nice paper. And I presented this usually as one of the highlight papers last year. Yeah? What if fever persists? That's the other thing. We were, like in our hospital, and I think in many hospitals was this. You came in on Saturday morning at 8, and the nurses, since 4 o'clock, 72 hours are already gone, so we have to change our antibiotic therapy, and this is not necessary if the patient is really doing fine. You have those patients, and most of them, they are febrile, and if they're febrile, okay, then they're doing not that well, but overall, over those days, they're not really deteriorating, so you should keep your antibiotic therapy. However, in those who are still febrile, if this high-risk patient, then you should think about empirical antifungal therapy and then do also a galactomannan and maybe a CT scan. This depends a little bit, you should do, but the empirical antifungal therapy, if they are neutropenic for more than 10 days or expected neutropenia, if they are having, despite broad-spectrum antibiotics, persistent fever, then you should think about doing this, and the recommendation is either caspofungin or liposomal amphotericin B. These are 6 o'clock now. It's, I'm almost done, I'm getting there. We have good data from adults, we have good data from smaller populations in children, and these are also approved for empirical therapy. Antifungal therapy, if you have like a proven, probably you can really go back to all these. I mean, there are a lot of guidelines. I just wanted to highlight, I have, I think, 3 slides on that. Invasive candidiasis, it's the efficacy against Candida parapsilosis, it's in vitro, it's quite low. And we always have to fight if they're doing, because we have this empirical antifungal therapy with caspofungin, and then it comes back, oh, Candida parapsilosis, the patient is doing fine, so we keep caspofungin usually. And this is also according to the guidelines. It's just that one knows that they have in a lower in vitro sensitivity. No CNS penetration usually with the candids, and candidemia you have to do after the last positive blood culture 14 days, and you should do really a fundoscopy and an ultrasound of the heart to check afterwards, and also from the abdomen, I forgot to put it in there, whether you have this chronic disseminated candidiasis with the liver and spleen involvement. And just, you should think really hard, remove the catheter and the shunts. Aspergillus, it's here we have the voriconazole with an A grading, then the liposomal ampho B with a B. Loading dose with the voriconazole, you have to do the drug monitoring. It's a complicated, usually you have to do it several times, and you have to think about the drug-drug interactions. You should think to switch classes if you have one or the other as prophylaxis. And the isavuconazole now, they try, I mean, in the US it's approved, in the EU not, but they doing now, it will in the next few months, they want to get the approval for the, and I think that's also quite a good drug because we don't have to monitor it that closely as voriconazole. The combination therapy, we do not have any really good data or convincing data that it's much better. As everybody does it, if the kid is doing worse and worse and worse, we do it, but what I think it's good to have to re-evaluate after 10, 14 days whether it has a benefit or not, and then to stop or not stopping this. So I knew that I'm over time, so no summary to time constraints, but I encourage you to discuss these topics not with Bob, only with me in the next few days. So thank you very much.